Good afternoon, and thank you very much for the invitation to come here and report on our initial results and experiences and what we did in one small country in Denmark, where we had this possible task, which I know arises many places, and we are calling it the DPD, the Danish Palliative Care Database. Okay, so I will first give you just a brief update about Denmark, the place where this took place, and then a report about the results. But this is just the outline you'll see about the development, how we did the delineation, our quality indicators, some results. And I will have today I will go relatively quickly through the results, not dwell into the actual numbers, but more I think talk about the overall things, because otherwise we'll not have time to do it. I'll talk briefly about the perceived impact of this, about the research we're doing, our future plans and conclusions. So Denmark is a small northern European country with between 5 and 6 million inhabitants. It's maybe it's the highest level of taxation globally. It's at least at the very top. At the same time, we have a very restrictive policy about the level of funding of the healthcare system, which has been kept, in fact, surprisingly limited through many years. So we have a very tense situation in the healthcare system with large demands and not that much supply. But it's all public, more or less. It's an NHS. For all that relates to cancer and chronic disease. We have a very small private sector, but it's not related to palliative care, except what I'm going to talk about hospices. We have traditionally had a very strong primary care sector, which served as the gatekeepers for the rest of the healthcare system. And I think Denmark was the first country to introduce 24/7 healthcare or home care for everybody in the country in the 70s. So in fact, we didn't have anything called palliative care, but it was quite early that there was in fact implemented access to some kind of basic level palliative care all over the country. Concerning specialized palliative care, this started very late in Denmark compared to this country and this place. We had the first hospice in '92, the first palliative care unit at a hospital in '97. I was so lucky to be involved and appointed as the person to work full-time with research as the first person within this unit, which was given the obligation of doing not just clinical work, but also teach and research and so on in palliative care. But the next several years we had a very slow and totally uncoordinated development. We had some laws enforcing some expansion of hospices, and we had some regional initiatives about establishing palliative care. And everything was done as if it was the first time each place, so everything was unique. The last few years we have had a strong change because palliative care was incorporated in the Danish Cancer Plan 3 from 2010, which mandated the publication of newly developed guidelines for palliative care and clinical guidelines, and as well as recommendations about how to do it. And the emphasis was on the virtual interpretation of the WHO 2002 definition, including all life-threatening diagnosis, including an emphasis on early palliative care. And the guidelines emphasized that rehabilitation and palliative care are two sides of the same coin, and recommended a combined approach where everybody with the cancer, and this was just for cancer, were routinely assessed and then allocated to what was suitable. So a slow start and a strong mandate for development the last few years, and this is the growth curve over the last 2 decades. So you can see the very slow start, and then until 12 years ago it was very modest, and then we had a large expansion in the number of palliative care teams, hospices, and to some extent palliative care units, but that is still just very few we have of this. So our system is based on these 2 kinds of units. And the 18 hospices we are having now are defined as grassroots initiatives. In principle, it's usually local people who gather together and say, we need a hospice in our region, and then they compete, and in the end they are allocated reasonably geographically scattered, but usually in some nice fields with a nice view across the water, distant from any connection with the healthcare system. So that's the system we're having, and then when they are built, the government takes over and provides full funding for these privately owned units. And in strong contrast to this, the palliative care teams are fully integrated into the healthcare systems. They are located at greater or larger hospitals, and they are having the typical functions of outpatient care, home care, and being consultants in the hospitals and to others. And then very few palliative care units. That's not a model that has gained any kind of attention except in a few areas. They are all suited or placed in the capital region. So we can conclude that this is a field which is still in the establishment phase. It's still early. We have to learn a lot of it. More than half is established within 5 to 6 or to 7 years. So we are very busy developing the clinical expertise, educating staff, trying to really have specialists, finding out how to interact with the rest of the healthcare system. What about the knowledge transfer expected from specialized care, and how does this take place, and how do we refer the right patients at the right point in time? Of course, these are, I think, what everybody is struggling with, but we are certainly in the beginning. At the present point in time, 95% of patients referred to specialized palliative care are cancer patients, so everything else than cancer is still not a topic for which is, there's much interest in it, but there's very little specific activity related to specialized palliative care for non-cancer. Database has the starting point that we really needed some information. I wrote the initial application in 2006 and received a grant from the Ministry of Health to build this database. We appointed a committee of people representing various organizations, the Danish Society of Palliative Medicine, and a group of people involved in hospice and palliative care. And this group worked as a steering committee for about 1.5 years, having 9 meetings, having an academic secretary researching what was being done before, and doing an extensive literature review, which was discussed over and over again. And then we had to deal with all these questions about how do we do this. We wrote a proposal which was sent into public consultation, had a national meeting, gained consensus about it, and finally had it approved by the Danish Board of Health, which has the routine that if somebody gets this approval of the Danish Board of Health, it implies that all relative or everybody in the healthcare system are obliged to report to something which has been approved by the Board of Health. So this was a very, very important step that it received this approval, which mandated obligatory reporting of patient data and at the same time to freed us from the obligation of patient consent. As this was seen as a quality initiative, it was freed from patient consent to reporting. So we were able to obtain funding for this and have funding for this from the Danish regions that own the Danish hospitals and healthcare system, and have recorded all patients who have died since 2010. We delineate these reports by the date of death of the patient in order to just to have one way of organizing which patients should be in which report. This year this was taken further on, and all data are now electronically fed into various electronic systems as in the same time as they're being collected, and this has in fact come out of our control, and now there's nonsense data being extracted, but that's another story I can return to. But this development phase had these two parts, discussions, what do we want to achieve and what have the other people in the world who have published about this been doing. We were able to find 5 countries reporting various similar attempts from the UK and US, Australia, Germany and Sweden were the countries that where we could find inspiration from. But we agreed that we needed what we could term healthy indicators that could guide such a field which was in a rapid development by some measurement of are we going in the right directions and where are our initial problems. At the same time as building quality indicators, we wanted to build a basis for health services research so we could investigate this at that time totally amorph area where we didn't know anything about what was happening. So this is just the literature review, which I will not go into detail with, but the main point is that there's a lot of possible variables you can look at. So there's many possible solutions to this task of building national registers. And this is just from the 5 countries we looked upon at that point in time and what we were thinking about as the 6 as our plan at that time. So in the end we defined our aims to develop a quality development database for specialized palliative care, and you can see that's one delineation that we said specialized palliative care and a national research database for the same field. And that could be translated into 2 patient inclusion criteria, that all patients referred to specialized palliative care were included. And you can see that by extending the inclusion to people referred to, we got the possibility of looking at access among those referred, but who might not all be accepted. Furthermore, we said that each patient would be registered once per institution, because in this way we would have data for the admission to each institution, complete data saying how many patients are going to each institution, but we at the same time limited the registration to saying it's being done once per institution, because we don't want to collect too much data, like for example registering each admission, because everything that could concern longitudinal data about what happened afterwards should in principle be obtainable from other registers. I can say that is still the plan. It's not implemented to get all the rest of the data. So that was the delineation. Specialized palliative care, 1 patient, 1 time per institution. And concerning quality indicators, I could talk about that for a long time. This is the summary of our main consideration. First, we agreed at that point that our main problems were insufficient capacity. We had routinely stories in all kinds of newspapers and scandals and so on about people who were not able to get to the hospice they wanted to go into. We knew there were waiting time problems and so on. We knew there were huge geographic variations, and overall we had no activity about the numbers involved in this. So capacity was a huge topic. So we agreed that we need to get data about referrals, admissions, which could lead to the estimation of access, and about activity. So that was the first part. The second part was a recent series of publications about detection of patients' symptomatology, where we and other researchers had done studies showing that there would be benefit in doing an initial screening of patient symptomatology to obtain increased insight into patient symptoms and problems at referral to palliative care. So we chose that as the fourth topic. And finally, we had a lot of discussions about the importance of multidisciplinarity. And we had initially plans about measuring the multidisciplinary involvement in each patient. We realized that doing this would be extremely costly in registration and documentation and so on. So we gave it up from the beginning, but we settled on a simple standard which we ended up being very happy with, which was to say that at least once for all patients referred to specialized palliative care, this patient has to be discussed at a multidisciplinary conference in order to make sure that there's a multidisciplinary input into the patient course. So we defined the final indicator according to this. So that led to this is the abbreviated versions of the 5 quality indicators. The next slide will spell them out, but I think this is more or less it. It's about access to specialized palliative care among referred, waiting time among those admitted, the proportion of dying cancer patients who are admitted to specialized palliative care in order to measure the penetration of specialized palliative care, the proportion who are symptom screened at admission, and finally the proportion discussed at a multidisciplinary conference. This is the full definitions, but I don't think we need them here. So that was the first part of it, about settling for the delineation and the quality indicators, and then the next one was to establish some kind of reporting, and we established a web-based reporting from all of the 44 institutions, where they reported the few data which are necessary to build this database, which are essentially 2 A4 pages of paper. And a questionnaire completed by the patient if they have completed such a questionnaire. So we kept it quite limited, and it takes 2 or 3 minutes to enter the data per patient or something like that. This is the web screen. And the second part, which is still under implementation, is an automatized linking of our database with a number of registers in order to record the full activity taking place after referral or after admission and until death. This is extremely complicated, as I said before, and I can elaborate this, but essentially what we realized that you don't, as long as you don't have a register, you don't have a systematic coding of activity. So we are having to standardize all coding within this field at the same time. Anyway, this is that was the design and establishment of this database, and this is then a brief history of the results. We are publishing in Danish yearly reports it's an obligation for us, and we have published yearly reports of the patients that were in the database and died in the year of publication or the year of reporting. So we are currently working on our fourth report. We have a very high completeness of data caused by the fact that we are able to track patients and follow up, and we have obtained an extreme degree of compliance with this, I would say, of everybody reporting to the database, a 100% reporting of the patients they have, and a 99% completeness of the data in the database, again by making most of the fields mandatory. So what is happening in 2012, the last year, we had a total of more than 8,000 patients referred to specialized palliative care for the first time. And that is out of a number of cancer patients dying, which is 16,000. So it's about half of all patients dying from cancer in a year are referred to palliative care at some point in time. The next figure indicates that of those who are referred, 72 are actually admitted. So we have a loss of 28% in transition from a referral to admission. It can be refined a little by doing a bit more estimations, as shown in one of the next indicators. And as each patient can be admitted to more than one unit, we have a total of 12,000 courses, which means that approximately 50% more are referred to more than one place. We are not having early palliative care as a rule in Denmark. As you can see here, this is the number of days of survival from the day of first referral to any specialized palliative care team. So you can see the median number of days is 35, so the median time before death is 7 weeks for all. It's clearly longer for palliative care units and teams than for hospitals, where patients are referred at a median of 2.5 weeks before. And when you take into account some necessary waiting time, you can say most patients are referred very late, and we are in the phase where most patients are referred to palliative care very late in the disease course. We are having some figures here about the EORTC questionnaire showing the symptomatology of patients referred. This is the first year scores, and I'm not going into detail, but the point here is just to show that this is a reference group of average cancer patients, and this is the scores of patients referred, and the main point is that there's much more fatigue, dramatically more fatigue, appetite loss, and other things. So you can see a very high level of symptomatology in the patients who are referred to specialized palliative care, indicating that it's at least not at random, and there's a solid documentation here that the patients are really having a lot of problems. This is a quick overview of one of the first year results for all indicators. We had to define standards for each chosen indicator, and then we have the national results for the same indicator, and you can see the red figures indicate that we are not at the standard we had chosen at the beginning. What you can see further on is that we are having 5 regions in Denmark, and there's very considerable variation between the regions in each of these figures. And this is another way of giving a quick overview of the results. It's the longitudinal development in the same numbers as you saw before. The national data where the indicators are or the standards are the red lines, and you can see that we have a quite modest development. In fact, we are having a deterioration. We are having almost no change in the first. We are having a deterioration in waiting time with a even lower number of patients who are admitted within 10 days, whereas we are having increase in the 3 other indicators. The proportion of patients admitted to specialized palliative care. This is a very, I cannot in any way defend this line, but we had to set a line, but we cannot say what is the right proportion. But we can see at least an increase corresponding to the increase in capacity, and we're seeing increases in the proportions of patients screened and in those discussed at multidisciplinary conferences. I'm just giving you a few more examples. This is a copy of one of our busy, a little part of one of our busy slides showing how data are presented with the standard and the regional data as in the previous slide. The figures for each unit, so it follows or continues for 2 or 3 pages with figures for each unit sorted by whether it's a palliative care unit or a hospice. And there's also the data for the previous years. And this is an even more busy slide, but this is just an example of how we present the data per unit. So this is the various palliative care units, and this is their results for indicator number 1, the proportions of patients who are admitted to them who are actually admitted. And again, you can see huge variation between units. And those units here are those where it's very difficult to get admitted, either because they are lazy and don't admit any, or because they're simply so popular that everybody wants to get into them. So, of course, the first thing was just to say that we cannot prove what is the cause of lack of admission. But this is something which can be used at a geographical level to see where are the bottlenecks and to what extent are people in our region able to get admitted compared to other regions. And this is, of course, done for each indicator. So I'm not going into detail, but I'm just showing a few slides illustrating some of our ongoing plans or work with investigating these data in a more research-oriented matter. This is more or less the same data we had before, but just to illustrate that one of the first things we are looking at in a PhD study is what are the relationships between past activity, patient characteristics, and admission to palliative care, and what are the relationships between that and later outcomes. This is just a draft model. You can, of course, make many others. The second PhD study is a PhD study which is just starting now, is about these URTC scores in admission and how they relate to past events and future events. And finally, we are having some plans about studying costs in this study, and of course there's very much more to do. I also said that I would say a little about whether this database had any impact on the development in the country. We have for sure documented a lot of a lack of capacity in this, and we have seen some quite extensive development, as you could see in the growth curves taking place at the same point. So we have documented that quite significant proportions of patients who have been referred to this and who have volunteered and who have probably looked forward to this referral are in fact lost in transition. It's about a fifth at the moment. We have considerable waiting time. We have huge regional variation, and we have seen an expansion of capacity related to this. We have seen very large variation in proportion of patients screened, ranging from 0% to 80, 90%, and seen an increased attention and appreciation of screening, leading to improvements in this area. And finally, we have seen this one, which has proven to be probably what we can be most proud of, a fence against a lot of battles about to what extent do you have to man your multidisciplinary or your specialized palliative care teams with more than nurses or doctors? Do you have to include more disciplines? And we made a stupid rule that as I said, every patient had to be discussed at this multidisciplinary conference, and you had to have 4 disciplines represented at the conference and note which disciplines were there. And in order to comply with this, people have to appoint physiotherapists and occupational therapists and psychologists and psychosocial workers and priests and various other solutions. So this has in fact probably been the most powerful indicator until now. We made a very vague initial attempt at disseminating results. I had an interview with a journalist, and the next day this was the result at one of the national newspapers, in fact the Christian newspaper. Dying patients are not helped, which is a translation of the fact that every 5th patient who wants to get into specialized palliative care doesn't get there, either because of being declined or because the waiting time is so long that they deteriorate in the meantime. It was copied onto Reuters Denmark and entered into almost all newspapers, all net media, a lot of TV programs, and I was interviewed twice to national TV stations, all within 24 hours. And after that, there was total silence. But yeah, it's remarkable how sensitive this area and how difficult it is to talk about it with nuances. The next planned steps we are having, just to finish up, is to get a track at what happens from patients admitted during the rest of their life by drawing this data from the registers we are having. But as I said, this is very difficult and it takes much more ICT capacity and so on than expected. We want to measure palliative care outcomes by having a second patient questionnaire, although we realize we cannot do that for all patients. And we are going to, first as a research project, explore the bereaved relatives' perspective by using a Danish version of the newest Voices short form questionnaire by permission. And finally, we are looking forward to having a stronger integration with this between this database and the electronic systems being implemented very slowly and very poorly currently in the healthcare system, but more I anticipate they will come. So an integration where we are getting this data more into the system is coming. So in conclusion, it was possible in this case study to obtain a very high level of consensus about how to build a national database, a very high compliance and satisfaction with a national database. I have to say that now that data are being used more and more and more, everybody is scrutinizing every comma and detail in all our indicator definitions because they are being held responsible for it in audits all over the country now. But we are still having a positive reputation. We have seen in the first years problems with access, large geographical variations and several improvements. So according to this, we could see some initial signs that the quality improvement circle seems to work. And clearly this is just the beginning, and we look forward to going on to continue exploring how we should conceptualize the quality of specialized specialized palliative care in the future. And in addition, certainly such databases are a very good basis for health services research. So thank you for this part of it, and thank you to those who have made this possible. Thank you.